Today we are presenting KR. She's a 13-year-old Hispanic female presenting with her mother and brother. They live in a single-family home along with their father. They are Spanish-speaking. KR is bilingual with Spanish and English-speaking skills as well as her brother. She's a reliable historian. Her mother encouraged her to be seen in the clinic today as her abdominal pain has caused her mother great stress. The patient's insurance is Medicaid, and Dr. Woodruff is her primary care physician who she has come to see today. The chief complaint is that the patient is concerned and states that she's had stomach pain for over a week. For the HPI, this is a 13-year-old Hispanic female that presents with a new onset of abdominal pain for over a week. She has no previous medical history or surgeries. The patient is unsure exactly when symptoms started, but know it's been over a week. When asking the patient to point to the pain, she points to her entire abdomen, indicating generalized abdominal pain. The pain does not radiate, the character is constant, and is a 6 out of 10. Her last menstrual cycle was 10 days ago and ended about 5 days ago. The pain has not subsided, and she states that it's different than period cramp pain. She states that the pain, nothing relieves it or aggravates it, and describes it as constant and dull throughout the day, not increasing at any certain time. Her last bowel movement was over a week ago. She states that she's also had a mild headache that is no longer present. She denies vision change, vision loss, blurry vision, denies recent trauma to the abdomen, recent car accidents, or other injuries. She has not had any decrease in appetite, weight loss, or weight gain. She denies fever, chills, and fatigue. She's not tried any home remedies or over-the-counter medications, and lately it's been making her hard to focus in school because of the pain. For her history, she has no past medical or surgical history or hospitalization. She's up to date on her immunizations, denies alcohol, tobacco, recreational drug use. She attends Mass at a local Catholic church that she's very involved in, is not involved in after-school activities. She does not exercise. She has many close friends, and no bullying or behavior issues are present. She states that her diet consists of a lot of Hispanic foods. She loves to eat enchiladas, nachos, chips, greasy meals, and doesn't really like healthy foods. She also states that she does not drink much water throughout the day, but would prefer sodas. She states that she is not, nor has she ever been sexually active. She's not using any contraception. Her last bowel movement was over a week ago, and she states that her bowel movements have not been regular, and lately they have been hard and dry. She has not had any recent travel outside of the U.S. KR is not allergic to any medications that she's aware of or any environmental allergies. KR is not taking any prescribed or over-the-counter medications. The ROS, general patient believes she is healthy other than her abdominal pain. She denies faintness, fatigue, or chills. HENT denies nose, throat, or allergy problems. Is unsure when last eye exam was or dental exam. Denies any vision problems or eye problems or nasal congestion. Dermatologic, she denies any skin lesions, rashes, delayed healing, or changes in skin. Respiratory, denies chest pain, cough, shortness of breath, wheezing. Cardiovascular, denies palpitations, skipping, or fluttering. GI, CHPI, denies nausea, vomiting, diarrhea, rectal pain, or rectal bleeding. Complains of generalized abdominal pain, different than period cramps. GU, denies dysuria, hematuria, incontinence, or frequency. Endocrine, denies heat or cold intolerance, denies polydipsia, polyuria, polyphagia. Hematologic, immunologic, denies abnormal bleeding or bruising. Musculoskeletal, denies weakness, joint pain, stiffness, myalgias, or back pain. Neurologic, CHPI, about the headache. Psychiatric and developmental, she's had some difficulty focusing at school due to the abdominal pain. Denies disciplinary problems at home or school. Denies depression, anxiety, or extreme routines. Time for the objective information. Her vital signs: blood pressure 110/82, heart rate 83, temp 98.0, respiratory rate 18, height 5'2", weight 155.2, her BMI is 28.4. Moving on to the physical exam. Generally, she is awake, alert, oriented, person, place, and time, well-developed, well-nourished, overweight, Hispanic female, and no acute distress. Patient appears confident as she enters the room with her mother and brother. The patient herself does most of the talking, appropriate eye contact, well-groomed, cooperative, good temperament. Skin is warm, moist, normal turgor, no rashes or lesions. HENT, normocephalic, atraumatic skull, no facial asymmetry, no lymphadenopathy. Thyroid is not enlarged. Perla, white sclera. Nasal and oral mucosas pink and moist, without discharge, lesions, or masses. No erythema or exudate on pharynx. No lesions, rashes, or masses to external ear structure. External ear canal has no redness, cerumen, foreign objects. Otoscopic exam reveals pearly tympanic gray membranes, anatomic landmarks present, cone of light present in appropriate areas. No bulging, retractions, or scarring. Neck is symmetric, midline, full range of motion, no JVD. For chest and lungs, AP lateral chest ratio is about 2-1. Clear to auscultation, no wheezing or rhonchi in all fields. Heart, no murmurs, gallops, regular rate and rhythm. Abdomen is soft, rounded. Spleen is not palpated, no organomegaly or hernia. Bowel sounds are normoactive in right upper quad and left upper quad. Distant and tinkling bowel sounds in right lower quad and left lower quad. Tenderness and guarding across entire lower abdomen upon deep palpation. Upon deep palpation, mass is palpated that may be stool. No rebound tenderness in all 4 quadrants. Musculoskeletal, normal gait and station, no asymmetry, tenderness, masses, atrophy, or loss of strength. Full range of motion in all extremities, negative CDA tenderness, no edema. Breast symmetry observed, no axillary or supraclavicular adenopathy. Lower extremities, no edema or deformities. Neuro sensation to pain and touch appropriate. No numbness or tingling. Genitalia deferred per MD recommendation. And no labs were performed at this time. Moving on to the stressors. The 3 main stressors noted in this interaction were abdominal pain, finances, and faith. Per Fawcett and Neuman 2011 are the following definitions. Flexible line of defense protects the normal line of defense. The normal line of defense is the normal, healthy state of the individual. Lines of resistance are the response to the stressor, for example, increased white blood cell count in infection, and degree of reaction is the amount of system instability. So just going through some of these, abdominal pain can affect her basically in all the 5 areas: physiologically, psychologically, socioculturally, developmentally, and spiritually. It affects her intrapersonally as she is experiencing physical pain. She's having stress and concern. She's not able to interact with others as she normally does. She may feel defeated through this. In this stage, she is in Erikson's theory of development of identity versus role confusion, per McLeod 2017. She's 13, trying to figure out where she belongs in society, so this may slow her down. She maybe is distracted when she's in church also. And interpersonally, it is affecting her interaction with her family, her friends. At school, she's not able to focus as much. So this affects her in all those areas as well. And finances is the main extrapersonal stressor. So because of the physical pain, finances may be an issue with paying for medical costs. That may be a big concern. And moving on to the differential diagnoses, they are constipation, pregnancy, and urinary tract infection. Starting with constipation, it is a symptom-based disorder characterized by hard stools that are difficult to pass or infrequent stools. This is by Uphold and Graham 2013. This occurs when the distal colon and rectum store feces and defecation is postponed. It can be caused by inconsistent bowel patterns, lack of fiber in diet, insufficient water intake. Can also be associated with poor diet, low income, low educational level. This is also by Uphold and Graham. There are 6 different criteria factors: less than 3 bowel movements per week, straining for bowel movement, hard stool, sensation of incomplete defecation. And moving on to pregnancy, it occurs when egg is fertilized by sperm. Diagnostic criteria includes history and physical. You can also do labs and ultrasound. Diagnosis is made by several factors: missing a period, presenting with nausea, vomiting, malaise, breast tenderness, other signs, Hagar sign, Chadwick sign. Really, the positive serum test is most predictive, and even fetal movements, all these can diagnose pregnancy. A UTI is a urinary tract infection caused by bacteria or other organism that enters the urinary tract. Females have a short urethra, which make them more prone to UTIs. Other risk factors are structural problems, diabetes, tampon use, sexual activity. After puberty, UTI increases the risk more significantly in females, and symptoms are typically urinary urgency, pain with urination, nocturia, suprapubic heaviness or pain. This is also by Uphold and Graham 2017. So based on all these factors of positive and negative case data, constipation is the most probable. So after careful review of history and physical, the diagnosis of constipation has been reached. Constipation related to poor water intake and lack of fiber in diet, as evidenced by lower abdominal pain upon palpation and lack of bowel movement for 1 week. Diagnostic interventions are secondaries. They will help identify the process. This is by Curley and Vitale 2012. And role competencies involved are direct clinical practice, leadership and guidance, and coaching. Hamric et al. 2013. These diagnostic interventions will be a thorough history and physical, a urinary pregnancy test to rule out pregnancy, and a UA to rule out UTI. An osmotic laxative of 1 ml per kg per day will be given to the child's regimen to soften the stool and help her have a bowel movement. This is a tertiary intervention. It may take up to 48 hours for desired outcome. This is from Hippocrates 2017. And competencies of leadership, guidance and coaching, and evidence-based practice have been implemented. Hamric et al. 2013. We'll want to teach the patient and family to increase water and fiber intake, add in exercise, and this is from Curley and Vitale 2012 and Hippocrates 2017. Also adding probiotics, Huang and Hu 2017, and establishing a bowel routine with a schedule. These measures will help prevent, so it's a primary intervention, other problems, but as we're doing this to help alleviate the symptoms, it'll be tertiary. For referral and follow-up, she should follow up within 3 days if she does not have a bowel movement, or she should go to the ER if pain, chills, nausea, fever, diarrhea lasts for longer than 24 hours. This would be a secondary intervention, as it would be identifying a disease process. The main goal will be to take the osmotic laxative and perform the lifestyle modifications so that the patient can have a regular bowel movement, as evidenced by stools that are regular in timing and consistency. A bowel movement should be achieved in 3 days and written in her journal. If it is not, follow-up is recommended. The hypothesis: if the patient takes the osmotic laxative and increases water, fiber, probiotic intake, as well as physical activity, constipation will be resolved and prevented in the future. If there's no resolvement of constipation, then She should come back to the clinic within 3 days. At that time, a referral to a GI specialist may be given. If these symptoms are persistent for several months or 1 year, referral to a GI or surgery is recommended. Hippocrates 2017.